and stuff. Cool. Right. Sorry. I think that's right. So, hello everyone. Very on the outskirts. So, I met some of you before. My name is Angus. I'm currently the spinal fellow. My background, so I went to Birmingham Uni. I did a year of anatomy demonstrating. I did 2 years as a teaching fellow, and then PG Cert, medical education, some other courses, because apparently having 3 years as a full-time educator is not enough to get you through CCT. I'm dyslexic, which dyslexia we know why it's important, but most people don't think teach particularly well. So what I want to talk about today, I'm the current spine fellow over in Oxford. So what I want to talk about today is Cauda equina syndrome, and just go through a few things about it, primarily touching on what is it, how to diagnose it, a bit about imaging and timing. I'll touch on the guidelines a little bit really. So the first thing, and it's really important to do, is that basically everything you come across in your medical career is to define it. Okay. So firstly, what is Cauda equina syndrome? It's going to have to be some back and forth here, just to forewarn you. I don't expect you to be right if that helps.
Compression of the Cauda equina.
Okay, that's a good starting point. So someone has compression of Cauda equina. Do they have Cauda equina syndrome? So you need to improve on that definition now. So that's a good basis.
They have to have symptoms.
Elaborate.
So if they have symptoms of saddle-shaped hypothesia,
of
saddle-shaped hypothesia,
okay,
or sphincteric affection, of, in addition to an evidence of compression, that would constitute Cauda equina.
Okay, so should we tidy that up a little bit? Okay, so firstly, what is the Cauda equina?
Part of the spinal cords beyond, I think, L1, L2, which
Is that still part of the spinal cord?
sorry?
Is that still part of the spinal cord?
Okay, that's where the spinal cord ends.
Yeah.
But it's the nerve endings, from which point onwards you don't actually have specific roots.
You do. So what it is, so you've got the spinal cord, which is a thick tubular structure, and it gives off nerve roots. Okay? It just happens that it stops and gives off all the nerve roots down at the bottom. Then you get dangly horse's tail, which is literally what it looks like, isn't it? So the Cauda equina is the group of nerve roots beyond the cord. As I said, it's around L1 when it finishes, which is why you can't get Cauda equina higher up, because it's just cord compression. Okay? Still devastating, right? But not Cauda equina syndrome. So we know what Cauda equina is now. Okay? So you touched on sphincter dysfunction. So let's try and tidy that up. So we've established its compression. So it's mechanical compression of the Cauda equina, which results in what? Tidy up what you said.
Autonomic dysfunction.
Same in terms of sacronerves compression.
Yeah, tidy up. So it's really looking at bladder and bowel and sexual dysfunction. So tell you that. So Cauda equina syndrome is compression of the Cauda equina resulting in bladder, bowel, sexual dysfunction. Okay, that is what Cauda equina syndrome is. Okay, you've then got the next question: when does it become Cauda equina syndrome? Because it's kind of a grey scale of whether they've got some symptoms or not quite. Okay, so as part of that, what other symptoms do you get with it?
Back pain.
Yeah, so you normally get back pain, okay, especially if it's acute. You get some numbness, so you can get sensory disturbances affected by whichever nerve it happens to be pressing on. What else can you get with?
Foot drum.
Yeah, power. Okay, so all the things that the nerve might do, that if you squeeze it, all the things it does, it might not do. So the key bit, those are all additional bits to it. So if you don't have the bladder, bowel, sphincter disturbance, sexual dysfunction, don't have Cauda equina syndrome. Okay? So you can have leg weakness, leg numbness, radicular pain, so there's pain on nerve root distribution, sensory loss. That's not Cauda equina syndrome. Okay, so then we've got to look at, okay, so this is dysfunction of things that control your bladder, bowel, penis, vulva area, okay? What are those nerve roots?
Okay, so first, do you have to have all of those things which you call Equina syndrome or any of them?
Any of the sphincter disturbances or sexual dysfunction. So the radicular pain, the back pain, all that sort of stuff, power, everything like that.
Yeah, but sorry, of the bladder, bowel,
Yeah, no.
can it be, do you have to have all
Nope.
3 of those? No, so
No.
any of those?
Any
things.
one of those. That's why I've said some form of dysfunction. So not that they don't work, but they're not working normally. Again, there's a grey scale of that, which we'll get to. Why? Because it's not just, blood's not just on off. Okay? There's different nerves that do different things within it. Okay? So, what controls those things? You all know the line.
L2, 3, 4.
No, L2, 3, 4 keeps the leg up foot off the floor. Three quads. C3, 4, 5 keeps the diaphragm live. So,
S3, 4,
and
5.
S2, 3, 4 keeps the shit off the floor. You've not heard that?
I've heard the 3 P's on the floor.
Keep the 3 P's on the floor. Yeah, okay, true. Good. Penis, P, and P. Okay? So, now you know what the Cauda equina is. You know what Cauda equina syndrome is, which is dysfunction of your bladder, bowel, sexual organs. Okay? And now you know what nerve controls it. S2, 3, 4. Okay? So then you can apply it. So obviously, that if it's a problem that's higher up than S2, 3, 4, you might get your lumbar 2, 3, 4, 5 involved as well. So that's why you get a spectrum of problems. However, if this is a low down problem that's only hitting S2, 3, 4, don't forget you've got L1, L2, L3, L4, L5, S1, which control your legs. They might be completely unaffected. So it might purely be sort of saddle pain or bladder bowel without any radicular pain, because it's not hitting those nerves because it's low problem. Obviously, it could be higher because you might hit it. Is that clear in everyone's head? Okay, so now you know what it is. Now you can then go, okay, so now we need to look into the mechanical causes of it. Okay, it's just literally it's compression of it. So you just go through kind of what can cause pressure. So what are the things that can physically compress the Cauda equina?
Hematoma.
Hematoma. So that's you. Again, a lot of this is called pattern recognition and picking up. You hear something and you realise, okay, that's a risk factor for that, so I need to think about that. It could be this, which then can help you later when you're thinking about how to sort it. But that's for later. You need the background. So your patients on blood thinners who go for surgery on the back, okay, higher risk. That's why we stop it. Okay, patients who have trauma around the back, they've broken the back. That's fine. Okay, there's no bony pressing it. But then over the next 24 hours, they have a hematoma that starts developing, gets bigger and bigger and bigger and bigger and so forth. Okay, so hematoma.
Disc prolapse.
Disc prolapse. So the lower ones are the most common ones. So you kind of 4, 5, and 5S1, just because mechanically those are the ones that take most of the load because the angle of them as well. So you most likely have disc prolapse. Okay.
Space occupiers.
Good. Space oriented. So when you get into that, you're really talking about
Tumours.
tumours. Okay. And in particular,
Meningioma.
is that common? You hear no, do you say zebra?
Metastasis.
Mets. Okay? Most common cause is Mets. So you get a lot of medics calling you because you get metastatic disease. So you've got something that, one, can break the bone and then cause problems. Two, can cause growth of a lesion. Primary cancers in the spine are rare. All sarcomas, they're rare. Okay? However, as we're all living older and living worse lives, cancer is more common, and we're surviving the cancer. So it's great if they survive the cancer, they still have metastatic disease. So people are getting all these sort of mets everywhere. And the oncologist is going, yeah, they've got 4 years to live. And you're like, oh, so not like 2 weeks to live, like, no. Okay? So cancer is the most common one. Then you go into your disc prolapses. Anything else? We've talked about hematoma.
Just trauma in general.
Trauma, yeah, so fractures can cause this. Obviously, big, unstable fracture, big retropulsion of the posterior wall of the vertebrae. Has to be quite significant. in order for it to do that. Okay? Anything else? Infection? Yeah. Anything, again, that can cause instability. It could be a collection of pus going through it, and that can cause problems across there. Okay? And yeah, it can be anything that just creates it smaller. It can be congenital, okay, or contributed by being congenital. Okay, so disc prolapse in me or you might be fine, but in, say, someone who's got achondroplasia or Down syndrome, where they've got a naturally slightly tighter canal, they can't cope with it, okay? Or they get a bit of degenerative stenosis. The degenerative way, i.e. facets at the back get bigger and they come forward, okay? Or they grow forward rather than they move forward, they get bigger, so you're pressing from the front, from the back, sorry, and then you get a little bit, maybe a slip, so that's what we call the spondylolisthesis, where the bones slip on top of each other. The combination of that plus a little disc prolapse can cause it. However, that tends to be chronic and slow, and so you don't get the acute symptoms from it. Okay. So we now know what it is and stuff. So how does this happen? Okay, this is where I now apologise for my drawing skills. So we have the bladder. We have S2, 3, 4. 2, 3, 4. Okay. So firstly, I'll give you a slight hint. So something comes off there, goes down and slides here. So we're saying this is the sphincters. Okay. Talking about normal function now. Okay. So what type of nerve is this? Correct. Okay. Good. I like that. Don't jump in with a really detailed answer. You say it's like when you say broken hip. Oh, you need an arthroplasty, or you say you need arthroplasty, not you need a hemi. You don't know until you found it out. So autonomic. Okay. Slightly better answer than autonomic. You said the simple one. No. That's kind of talking about somatic. Okay, so there's a motor element to it. So autonomic then breaks down into. Okay, so we've got S2, 3, 4 is parasympathetic. Very good. Okay. Then you've got down to kind of L1, let's say, and there's something that comes up here. They all combine. That goes into here. So that's going to be T10 to L1. Is that one?
Thoracolumbar sympathetic?
Yeah, it's a sympathetic, so it's off the sympathetic chain. Okay, so that's higher up here. Okay, so that's your sympathetic. Okay, this is a bit oversimplified. Okay, and then there's another one that comes off from these. Combine that goes into here. Okay, what's that one?
Somatic.
Somatic. Okay, so that's somatic. That's the I know what I'm doing. Okay. Anyone know the name of that one? Have a guess? Sorry? Very good. So this is a very key lesson you need to learn. Don't look like you're guessing when you make a guess. Have to think about it, stop and go, I think it's a pedendal. Okay, you're right. However, I now know you've guessed it. Like, did you just completely let it go? You didn't really know that. You'd be surprised once in a half knew you were right. Good skill to have. I'm not saying completely utterly guess it. Say, right, it's definitely this. I think that. Okay, so sympathetic, parasympathetic, and somatic. Okay, this is also got a bit that comes up into here. So, what does your parasympathetic do to this sphincter normally? It relaxes it. Okay, so this normally causes this one to relax. Okay, now and what does your somatic do?
You can relax it when you want to void.
Yeah, you can relax it. You can plus minus do it on and off. Okay. So your parasympathetic, okay, is firing to help you relax. Okay, and then sympathetic comes in here as well. What does your sympathetic do to that? Contracts it. So when this is firing, this is causing it to contract. Okay, so which is firing when you're stressed? Parasympathetic or sympathetic? Sympathetic. Can you pee when you're stressed? When people are watching you? It's quite difficult. Okay, that's because your sympathetic is winning the battle here. Okay, and you're not able to kind of when this fires, it kind of inhibits this one. Okay, so it causes the contraction. So you need this one to be working to allow kind of a negative inhibition of here to allow it to relax. Okay. The parasympathetic goes up into your detrusor muscle as well. What does it do when it fires in here? So when you're nice and relaxed and you're going for a wee, do you want your detrusor muscle to contract or relax?
Contract.
Contract. Okay. Not everything parasympathetic is to relax, relax, relax. Okay. So that needs to fire. And obviously sympathetic does the opposite. So you've got a natural resting tone. Natural resting, don't do anything, don't do anything, don't do anything. Until this comes along and goes, da da da, stop doing that. Stop doing that, you need to do something. And then you get the natural tone building it, which then gives you that. You can also got a bit of extra control, and you can bear down and think actually squeeze. Okay? So, that is what is going on here. Does that make sense? So your sympathetic relaxes your bladder wall, okay, but causes this to contract. Parasympathetic tells this to contract, and also tells this to relax. Okay. You've also does a bit of sensory in here. What's that?
Let's try again.
Yeah, it's a trigo. Good, good. Okay. 2 in, 1 out. Okay. What's it important for?
And pressure sensation.
Pressure. So that's an important pressure sensor. Okay. Remember that. It might be useful when we talk about things later. It also got some stretch receptors in the bladder. Okay. From the parasympathetic. So that makes sense. Okay. So then think about what happens. So you have a disc prolapse in your Cauda equina, which is below L1. So what's spared? Sympathetic. So now you don't have to remember everything, you can work stuff out. Okay? I'm terrible at facts. I can't remember facts. Just because you remember facts doesn't mean you're clever, doesn't mean you understand something. If you understand it, you can work it out, you're much more likely to remember it later on and apply it to slightly different situations. I'm sure you will come across it. It's a spectrum of how they present. And you're like, oh, is that really that? Because obviously there's other conditions as well. And they can be really, really subtle things in the history and examination. Okay? So, we've still got sympathetic, so what do we still have?
Relaxed bladder with constricted.
Yeah. So they've got a balloon that's nice and relaxed and fill up, and nothing down here that we can control. Okay. So now we've lost these, or they've potentially just been interfered with, i.e. it's not 100%, but it's not 0. Classical full blown. So what happens? So what's happening? So what happens when you've still got sympathetic and parasympathetic? So can you contract your bladder wall? No. Can you relax your sphincter? No. What happens? Retention. So rather than just saying retention, what happens? It slowly fills. Okay? This balloon fills and fills and fills and fills. What happens? So let's just go back to how does this valve work? Pressure. Okay? This doesn't completely seal it off. It's not like the wall here. This is that. Okay? And I've got a tube going through that. Okay? So if you push down hard on the plunger, when you push lightly, nothing's going to happen. As it gets bigger and bigger and bigger and bigger and bigger, the pressure builds, doesn't it? So you're pressing down the plunger harder, 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 until what happens? It's enough pressure. Yeah, so there's enough pressure to bypass this valve, and they wet themselves. But they don't have proper sensation around here. So they go, how do they know they wet themselves?
Trickles down.
When it touches some point of the body, it's nothing.
They go, oh, my legs are wet. They go, didn't know I need a wee. They've also lost the sensation, so they didn't know they needed a wee. Okay, so they lost the urge. Okay, when you've got 300 mils in your bladder, you need a wee. If you've got 500 mils in your bladder, you bloody need a wee. Okay? You know about it. Okay? And you press, especially if you press and you go, oh, yeah. It's because you've done a sudden spike in your pressure on here. So when you burn down as well, because you have a pressure in there. You've all seen that graph where the way your brain works, so you get a spike of, you need a wee, relax. You need a wee. And next thing is, no, you really, really need a wee, come on. And then pressure spikes go higher and higher as the signal to the brain. So this obviously then your wee comes out. What happens to the pressure? It goes down. What happens to the sphincter? Closes. So, what's your post-void bladder scan?
Still be quite high.
High.
Higher than 400.
Yeah. So I'll get onto that in a bit. So, but it's not normal, is it? Because the pressure goes down, and then you kind of, because you're still firing with this, with this, sphincter closes. Okay, because you're still telling it to dip, but it's just not strong enough to hold it. Okay, well they've bent forward and just spike the pressure and it's gone. They get incomplete voiding. Okay, and then obviously these nerves as well. Okay, just think about from your erections. Okay, point and shoot. Okay, so you lose the from males. It is actually important to ask about why you still able to get an erection. Okay, and one caveat to that is asking men, do you still get morning erections? So if they still get morning erections, depending on the time frame, obviously things might happen since then. If they wake up with a morning erection, okay, that's obviously still working, and it's a different course because obviously there's multiple different reasons for it. And I've certainly had patients who borderline this, and then actually he's like, actually no, I still do get morning erections, but he's having a sexual problem. There's a psychological element to that. Okay, so like I was saying, there's many other reasons to be incontinent, aren't there? Many reasons. Many reasons to have sort of pain in your legs and stuff like that. There's many reasons to be a bit numb and stuff. It's not always called Equina syndrome. Okay? And this we're going to figure that out. You tease it out by first understanding what's going on. Then you can delineate what type of incontinence it is and just build this picture. Okay? What's the problem with building the picture? How do you diagnose it? Okay? It's hard to make a diagnosis purely on your clinical history. Okay. So you've lost your parasympathetic, that's particularly why the sexual dysfunction. The S234, that does all your genitals and over on there, which is why they get either labia or testicle or penile or perianal reduction of sensation. Okay? Understand? Yeah? Good. So now you understand the pathology. You understand what normal function is, okay? And it's just you break it down, parasympathetic, sympathetic, somatic, okay? You all kind of, now I've said this, you probably go, oh yeah, I remember that school. I remember those 2, 3, 4 kids that sit off the floor. Everyone remembers point and shoot, okay? So, you understand how it's going, and then you can work it out. So, we then go into your patient, okay? So, what are the pertinent questions? So, they present normally with leg pain, back pain, and some urinary incontinence. Okay? So, you've got to break it down into the important ones. And what's also very important about the symptoms.
Duration of progression.
Yes. Okay? A lot of things. What's an orthopaedic emergency? Back to definitions again. So define emergency. Why is something an emergency?
Because if there's no intervention within a short period of time, it can result in complication of the mortality or long-term morbidity.
Yeah, exactly. So it's a time-critical disease process that results in significant morbidity. That can be death, loss of a limb, or loss of function. Okay. As soon as you start being, you see how you get these in that sort of time, understanding what things are. You're right. Okay. So within orthopedic emergencies, let's go through all the pathologies. You've got Kaye syndrome, you've got Equina syndrome, you've got infection. Okay, because they could all potentially lead to stuff if they aren't treated in a timely manner. Okay, that's why hip arthritis is not an orthopedic emergency. Okay, you can talk about pain or chronic. That's not an emergency. So, What are the classic symptoms?
I've got it right.
Yeah, no, not hypothesis. So, as you spoke.
Obviously it's like saddle paresthesia.
Yeah, so reduced sensation in the saddle area, sort of perineum, sort of perianally and sort of labia, penis, scrotum from there. Okay? It's particularly important to differentiate left, right, both sides. Why? Why is like I'm sure you get it, so I'll take the easy one. Bilateral radicular pain. So radicular pain is pain along a dermatome. Okay, i.e. pain caused by pressure on a nerve root. Okay, go back to definition. You hear radicular pain. So that's what it is. Okay, so you can then get that map out of the person. And the areas they cover are much more simple. If you look at a chart, not like this, but how did we evolve?
Walking a 4.
4. Put it as 4, and you look at it and goes, oh yeah, everything's straight up and down. That makes a lot more sense. So that's why it's like this. Yeah, okay? That's why it looks as it is, and it's on those dermatomes. So why is bilateral symptoms kind of a red flag?
Central compression?
Yes. What are you getting at with that?
Like spinal compression. It's bilateral.
Yes, because bilateral, what does it mean? So,
Central system compression.
yeah, you're there, as Steve can explain it. So that is your canal. Okay? So, which nerve roots are those 4 most likely, let's say 6, going to be?
It's 1 to 3.
2, 3, 4.
Yeah,
Okay.
2, 3, yeah.
I know how to do the levels very hard. Okay. Then you've got all the other nerve roots coming across over here. So, if you've got a disc here, and let's say it's an absolute doozy, okay? Given obviously, they're not all knotted, they're coming down in like this and going off like that, aren't they? So they're going to roughly be in line, aren't they? So the ones that are going up last are going to be in the middle, aren't they? The ones that come up first are going over there. So if you've got a big disc that's here, okay? So this is your left side, just because you're always looking at that. Then you have left and right side of symptoms. Most likely,
Left side.
left side. I don't ask hard questions, don't I? Okay? And again, if it's here. However, and so it's most likely, because these will just get pushed to the side, whereas this will get caught in the lateral recess, which is just a bit over here, or as they go through the foramen, it's just elbowing as it goes through a small tunnel. So if you've got a big disc that's here, but then you've got the same disc that's in the middle, okay, and it's got to be big enough to bugger these, because even if you disc that big, these nerves are going, well, I'm going to go over here. Okay? They're not pressed. You might start having a little bit, but obviously by the time it's big enough now,
What's that?
they're pressing them, it's not to scale, just to full body. Okay? They'll hit these, but it's also going to hit that side and that side. Okay? So that's why bilateral symptoms have a red flag. And so if you're doing the perineum, it's important to say to the left and right. Try not to get confused with the patient's lying on the side like this and you kind of going up, down, and you just flip everything around. It's amazing how much I can really think while testing it out. This is left and right, free documentation. Okay? So, that's why bilateral. So we talked about, so radicular pain, unilateral, yeah, you know, okay, there might be something that's pressing on a nerve, less likely to cause Equina syndrome. Pressing both nerves, okay, that's why you're worried about it, do something about it. Power, yes, that's important, but it's not important in the context of why I might treat it as an emergency, okay, because that's not called Equina syndrome. Radicular pain resulting in power loss. Have you ever seen that treated as an emergency, like needs stairs in the middle of the night? No. Okay. And the cord, yes, but that's different. That's a different thing. You might have cord compression in the middle of the night, that's fine. That still is an emergency. Okay? That's because the cord doesn't recover well. Down south, it's got
Treatment-wise,
no, not in treatment wise. It's damage is done.
so there's no rehab or any sort of
apart from time. Okay? So you break a bone, what happens? It heals. Okay? Barring IBD, smokers, diabetes, it heals. Okay? It's predictable. We are designed to fall out of trees. We're designed to break bones. That's why they're there, and that's why they take the brunt. Okay? What happens when you damage a nerve? Is there anything we do? No. We can stitch it back together, and then we go.
Let's hope.
Yeah, you might be able to do that. You know, kind of, it really is, isn't it? It's like, once the damage is done, the damage is done. Okay? And this is acute pathology. So sometimes it's a, okay, I've already punched my hand, I can still feel it. Okay? This isn't a press, crush injury where you slowly find pressure over time and then I take the pressure off. Because if you do that, I adapt. Okay? I push in with my other hand, it adapts, it's not a problem. Your kind of nerves can slowly adjust to it. Okay? You don't get the sort of cells traumatized by the sheer force of it. Okay? You don't have the ischemia that happens to the nerves. Okay? We've disrupted the microcirculation here as well. Okay? Is ischemic pain not so bad or really painful? Really painful. Because ischemia is nerves. Same as Parkinson's syndrome on that side. Okay? First thing to go is venous. Okay? So then you get ischemia of the nerves, and that's why it's really painful. Okay? Ischemia pain is bad. So, got off a tangent here now, wasn't I? So, what were we talking about? So we're talking about depression in the nerves. I completely lost my train of thought.
If you lose any on something, then.
Oh yeah, it's bad. Because the damage is done, that's a late sign, okay? Requires quite a lot of nerves to be damaged before we get to that point. Bladder symptoms. Okay? It's the age old, they're incontinent and they've weak themselves. So what people then get annoyed about is I then ask them questions about it. What questions do you think you want to know before you go, are they wet themselves, MRI scan? Everybody's wet themselves, do they need an MRI scan? No. Okay. So, you've got to go through all the reasons. Why might someone wet themselves? One, Cauda syndrome. We're going to take that out of the room so you can't say, right. Why else might someone wet themselves?
Because they have weak pelvic floors.
There's a weak pelvic floor, okay? And what are you trying to get out there? What's the definition for that?
Stress incontinence.
Stress incontinence, okay. Do they wee themselves when they stood up? Did they cough? Is this long standing? How long has it been going on for? Have they had 3, 4, 5 babies? Okay. Have they got stress incontinence symptoms? Oh, it's only when I sneeze I get a wee. Okay. Okay. So stress incontinence. Why else might you wet yourself? So that's kind of called Equina. Sort of thing, as in you don't have the urge to go. Okay? And you get kind of that overflow picture because there's an obstruction going through. What else might have incontinence? Who here reckons they eventually wet themselves if I locked all the doors? Yeah. Why?
Yeah, just retention, not retention, wrong word. Just
Overactive.
No? Is your bladder overactive? No? So I lock that door. And
overstretched.
What can't you do?
Go to the bottom.
You can't get there. And these are patients who are in pain, can't mobilise because they're in so much pain. So, did you have the urge to go, yeah, why did you wet yourself? Well, I needed the wee, but I was in so much pain, I knew this would happen. I was so much pain I couldn't get there. Okay? Or they've broken their back and they can't walk, They can't get to the toilet. There's an old day of the frame going through, so I just couldn't get there in time, I was at the flight of stairs, I wet myself. Oh, right, okay. So it's kind of, and then you get to the overactive bladders. Yes, they've got long-standing problems. Is there like a tumour going on? But that won't present acutely. You have a bit more gradual onset. Have they got prostate problems? Okay, getting dribbling, post-maturation dribbling, and that. Then we get into the grey scale. So we're looking at what's going on with the Equina. You get overflow incontinence, i.e. the bladder gets so full it empties a bit, but then it seals. They get the dribbling, so they can't initiate. So they may still have the urge, they may not have the urge. And you speak to them, they'll go literally like, yeah, I just haven't been for like 8 hours, and I've drunk like 2 litres, so I just went to the toilet and strained. I.e. they strained, they increased the pressure in the bladder so much that they bypassed it that. How did you know you went? Oh, I can hear it in the bowl. So you just see getting pictures. So you can say, did you go to the toilet? Have you wait yourself? No. Do you still have the urge to go? No. Okay, so why do you go to the toilet? I just, I normally always go for a wee in the morning. So I went and sat in the toilet, I couldn't go, so I fell down. Could you hear it in the bowl? Yes, no. They knew they went because they could hear it, not because they could feel it. So did you know you were going? Did you have the urge to go? Are you dribbling? I.e. they can't quite control the sphincter properly. Okay? It's all a bit stop-start. Again, it could be prostate, it could be other things. Okay? So this is why you have to narrow it down. Okay? How did you know you wakes up? Oh, it's because my legs were warm. Yeah. Okay? Did you have the urge to go? Yes, no. When was the last time you had a normal wee? Oh, 4 weeks ago. Okay? They might have an episode, but then it's come back to normal. Okay? So they're teetering around Cauda syndrome, not Cauda syndrome. Okay? Physical exam. So that's in the history. The other key thing, what's the most common cause of Cauda syndrome? No. Mets. So in your history, what do you need to ask about? Cancer. So if they were metastatic disease, so have you lost weight? Have you got a history of cancer? Okay, most common cause. So you just got to have that in the back of your head. Not so much when you speak to a 20-year-old, but you still need to have it there. And you going through your study of all the causes. Trauma. Did you just get hit by a car? Okay, you worked through this. The physical examination. Okay, back pain. Yes, you normally have back pain with Equina syndrome. If they've got no back pain, it's less likely. You can't examine it. You've got low back pain? Yes, no. Have you got leg pain? Yes, no. It's questions. You do sensory, you do your motor, you do your reflexes. Don't forget to break up to upper motor neuron, i.e. it might be something higher up in the cord, or the lower motor neurons. It's called Equina syndrome. Okay. So if they've got brisk reflexes, clonus, and bladder symptoms, yes, it might not be called Equina syndrome, but then if your MRI of your lumbar is normal, actually this might be a lesion higher up. They've got a sensory level around here on the waistline, then you just think cord. Okay, differentials. So, the physical examination, you can do the stretch test, that just says yes, there's a nerve, but it doesn't help distinguish with Cauda syndrome. Okay, it's just part of your workup for it. When you're doing the sensations and the powers and where the radicular pain is, just helps with your level check. Okay, so they go, oh, I've got pain here. So you L2, L3, L2, L3, L4, L5, S1, and the back. It just helps you build a picture, and then when it's not Cauda, which most of the time they're not, you can then see how much it relates to do the elective planning for them afterwards. Any questions about the history and the examination? Okay, so what are the sort of 3 key things in the history you're going to be asking about broadly? So, probably 4 I said. So time frame. Okay. What else about the symptoms? Yeah, so you're asking all about bladder and nail it down as we just talked about. The time frame for that. Okay, when it all came on, and the radicular pain just helps build a picture. Is it into your legs? Where? Does it go below your knee? If it doesn't go below your knee, it's unlikely to be sort of 2, 3, 4, 5. S1. Okay, but there still might be a 5 S1 distance gone down. And sad anesthesia. Is it numb when you wipe yourself? When did you notice that? Okay, and when did they last have a normal wee or something? Okay, because there'll be a medical legal thing that follows. Okay, so keys for documentation. Examination, it's PR, really. You've got weak power, fine ability to picture further stuff, sensation, fine ability to picture. It doesn't help you with the diagnosis of Cauda syndrome. Okay, so it's perianal saddler sensation, sharp touch, And have they got any alternative? Yes, no. Okay. Yes, the neurological examination is important from a documentation, helps build a picture, but it's not helpful for diagnosing purely Cauda equina syndrome. So, clear? Happy? You now have sort of the key sets of things that you're trying to think about. And you can relate it all back to this. Okay? You might forget those particular bits, and you kind of go, actually, hang on, I know how it works actually. When they start building it, you'll get repetition to it. So, imaging or investigations. Yeah, so you're going to decide who's going to be imaged and who's not going to be imaged. Because it's all grayscale. And what's the problem? Yeah, so getting an MRI in all places. We're lucky in here. It's easy to get, and then not get a GR, easy. Okay. Most places don't have it. So you're going to decide who gets MRI scan and what time frame. And you've got to pick up who should get scans and stuff. And that's where the guidelines come in to help with it. Okay? So, apart from an MRI scan, which is the obvious one, what other investigations are useful?
So, general investigations lab, we could do PSA. So, if the patient has prosthetic symptoms, it could be.
Yeah, that'll work for excluding, but we'll put my normal, unless you thought maybe you had metastatic prostate cancer.
Yeah.
Okay. So yeah, it might help you out.
I guess an X-ray could help if there is significant trauma, for example. That could at least point you towards the direction of Kaye.
Not really. So if you're thinking along those lines, I would get an X-ray. I'd get a CT.
Yeah.
X-ray won't. We'll say there is a fracture, but from the mechanism and everything else, it'll probably pick it up. Much more sensitive. X-rays a bit crap. If they're normal, great. It tells you there's no, but it doesn't really tell you anything. Even if they're normal, you miss a lot of stuff with that. And so if you're thinking, actually, this might be a traumatic process, or the fracture's completely collapsed down, CT would help that. But also, in all honesty, an MRI scan would pick it up. And then you can get CT later if you're actually, I need to look at bony architecture. What do we always ask for? How can I assess the bladder function?
Voiding cystogram.
So pre and post void bladder scan. Okay. So the reason everyone says 200 mils, okay, is that there was a paper which showed that if your post void bladder scan is under 200 mils, you are very unlikely to have Cauda equina syndrome R. I'll explain that in a second. At that point in time, so you can scan later, i.e. next morning. There's been further papers that come out since that one saying there are flaws in that and it does miss some. Okay? So yes, it's reassuring, but you've also got to look at your picture. I had leg pain going down one leg, it's now going down the other leg. Okay? Maybe a bit tingly in the middle, kind of things. You've got that acute evolving bilateral reduced pain with acute back pain. Okay? You still get scanned even if you've got no bladder symptoms. Okay? So that is useful, and if they've got retention post-void that's 400 mils, yes, you need to actively exclude it. It could be for other reasons, but you need to actively exclude it, i.e. could be constipated, they could be in so much pain they can't go. Okay? Lying in bed in absolute agony, it's quite hard to go for a week. Okay? Patients really struggle with this. So, what are the guidelines at the moment? Have you come across them? Doubt it, the rest of you. So you've got the girth guidelines that relate to Cauda equina syndrome that have come out recently. And they basically said if anyone's got acute back pain within 2 weeks with bilateral radicular pain or bladder bowel sexual dysfunction, they need to have kind of an acute MRI scan if the symptoms are less than 2 weeks old. It gets a bit grayscale when you talk about the timings, but you should go at urging it what you can, depending on how long the symptoms are going for. If you're going for 2 weeks, yeah, probably appropriate to wait till the next day. And the point of those guidelines really are to push to get more MRI scanners available at DGHs overnight because there's a lack of radiographers who do MRIs. Which is why you don't get them at DGH. You do CTs, there's enough. radiographers for CTs. They don't have this. So, does that make the disease diagnosis in your head a bit clearer about what's going on?
Yeah.
Do you feel as though you could whittle people out better than you could before? Yeah. So it's key really getting to the crux of the timing and exactly what that, just they're incontinent. It's not really good enough. Okay? You suddenly realise that this could be stress incontinence, in which case there'll be a longer history, or there's something else going on for it, we've got water infection. Don't forget about discitis, so signs of infection, that's when you CRP, inflammatory markers, or the blood's come in, inflammatory markers. Okay? Any questions? Anything do you think I've missed off? No? Would you like, it's a rhetorical question, because I know you're all going to say yes, we'd love to look at some MRI scans. So,
I'm going to have to go. I'm being asked to review someone, so I'm going to have to go.
Scandalous.
I've held them off for
Tell
15
them this
minutes.
is more important.
Well,
I've tried.
but they've beat me for 3 times. So.
Don't worry.
But thank you. That was very helpful from a diagnosis point of view.
Yeah, just understand it. If people don't understand it, they just solve biological, isn't it?
Yeah.
So,
Thank you.
So just with the actual bladder symptoms,
yeah.
if they're telling you a picture of, well, it's not the urgent incontinence or the high pressure that's resulting in incontinence and lack of sensation, are you confident enough to say, okay, this isn't called recliner? Or
You do it case by case. If I can find a reason for it,
yeah,
and it's clear the case. It's all about building a picture. There's no tick box for this.
yeah,
Okay. The problem is the symptoms are really varied,
yeah,
and so the reality is there's a low threshold for getting an MRI scan.
yeah.
If the patient having like very slow history of like progression in the compression of the spinal cord, and then they reach the point that now it's quite equine.
Mm-hmm.
So when you
So-
take the history, it will be like the duration more than 2 weeks. So now the priority for MRI will be what's regarding them.
Yeah, so if the symptoms have been static, I'll quantify it with that. So if they haven't changed in 2 weeks, okay, your priority to get an emergency MRI scan goes down.
But they having like a chronic slow and progress.
Yeah, so if it's
So the
progressed,
point of a Cauda equine compression.
I know, so they're not static, correct? They're not static, are
No,
they?
not static.
So if they're progressing,
Yeah, I mentioned progress.
yeah, I know, so it's been, so if they're progressing, then yeah, you've got to treat it as in this has changed.
But more than 2 weeks history.
Yes.
The duration.
Yeah, of course. Because,
Still having the MRI scan.
yeah, because they've progressed. So you kind of, so a simplistic way of looking at it, okay, this is their symptom, so this is their level of symptoms, this is time, okay, so that's their symptoms, okay, symptoms aren't changing, okay, now we get it to over 2 weeks, okay, you don't have, according to the guidelines, the urgency to get an emergency. Now that doesn't mean soon, that means, do I need to scan them overnight? No. Do I need to get an urgent scan as in the next day or 2? Yeah, okay? Because you want to preserve what you can, okay? So, if the symptoms are progressing
Yeah, that was my question.
in the past 2 weeks, okay?
Yeah.
And they're
Oh.
now still, so when should I stop? When the symptoms are this. So that's the next question. What's the objective? Because what's treatment?
Surgery.
Release the pressure on the nerves, which is normally in surgery. Okay, crudely, how are you going to do that? If it's infection, drain the collection. If it's trauma, reduce the fracture. If it's disc prolapse, do that. If it's cancer, radiotherapy, chemotherapy, all these things. Okay, so whatever, that's the broad scope. So your
But they
object.
don't get the MRI like in the same nights?
No,
Urgent
because-
MRI?
Well, no, you would, because if they're progressing, they're getting worse, they're getting worse, they're getting worse. I'm going to leave them. They're going to get worse, they're going to get worse, they're going to get worse, they're going to get worse. And what is the primary objective of treatment?
Prevent it from getting worse.
Yes, prevent it getting worse.
even if their history more than 2 weeks, they
Yeah.
will get an urgent MRI?
Yeah.
That's my question.
Because they're progressing. So the answer is
Yeah.
yes.
Yeah, that's
So-
my question.
So that's why I said, so if the symptoms are static for 2 weeks, yes, you cannot do a scan overnight. If they're progressive, and that can be a grey scale of what progressive, but they're changing. So the whole point is, objective of surgery is to prevent things getting worse. Okay? So we had 2 this week who had symptoms. When they are consented, we say the aim of surgery is to stop things getting worse. Okay? So if they're already up here, and they're doubly incontinent, and it's been 2 weeks, if it's a 20-year-old, you go, look, worth a shot. Or they might, if it was me, and I was at that point, I go, take me to theatre, thank you very much. They're 90, okay. Suddenly the risks of surgery start creeping up. The benefit aren't that great. And things are actually, okay, so now I've got risk of surgery with a very low benefit risk. So your benefits are still here, but your risks are now up here because you've got low comorbidities and you're 90. You don't really walk anywhere. You've got a catheter anyway, or your treatment is now a long-term catheter. And do people have that as their long-term treatment for other stuff? Okay, so your risks go up, but your benefits don't change. Whereas when you're, our age certainly, actually surgery is not really. Yes, you've got standard risk, but it's kind of the potential benefits of that 5% win. I take it. Okay, a bit like if I broke my hip now, and they said, look, if we fix your hip, but you keep your own hip, you've got a 10% chance of it working. Okay, I'd take that 10% chance. I wouldn't want a hip replacement at my age, because I'd probably ruin it, no problems. And if it fails, then I'd have a hip replacement, that's another argument. But you've got to balance the risks out with it. So you may at one point, somebody say, and I've had this before, where actually, given their symptoms, they may only be partially incompetent or whatever. You leave it like that. Okay. So you if they're progressing, you still need to stop the progression. If they've progressed and now they're static for 2 weeks, symptoms haven't changed for 2 weeks, which we've got one at the moment doing today, who I saw on Wednesday. She'd had her symptoms for 2 weeks. So it's urgent, but I didn't do it that day, I didn't do it the next day, we didn't do it the day after, I'm doing it today, because we've got a plan this to do it on. But we're not leaving her in the elective pathway to go back to whenever. Okay, but you've lost the emergency. Urgent, but not emergency. Okay, like then you talk about P3 rather than P2, P1. So that's your objectives of treatment, along with the time. And then you get into a real grey area, and there's huge debate about this. There's mixed evidence. You then go, if you need to do it within 48 hours, the removal of the pressure, whether that's radiotherapy, surgery, whatever, it's within 48 hours. And then so, well, do you need to do it 36 hours at 4 in the morning? Your risk of surgery go up at 4 in the morning. Okay, the tired surgeons, they've been on all week, they've had a couple of late nights work, and they're tired, they have a higher complication rate. And does delaying it 4 hours increase your risk anymore? There are some papers that look at basically, again, it's this whole risk stratification. What's your potential risk of permanent neurological damage? And again, it's this kind of line here. Okay, I think broadly speaking, it's 1% an hour. Again, if I had to wait, if it was 10 o'clock at night, I had to wait till 10 p.m. next day, 10 a.m. next day. It's 12 hours. It's 12% risk of increase in permanent damage. Personally, and again, this is different for different people, and depending on the time frame. You're in the first 48 hours. I'd say that's a 10% risk that I would like to reduce. Thank you very much. Okay. So that's the decisions you have to make. But those are complex. You've got to get it diagnosed in a timely fashion. So if it's acute, you get an urgent MRI scan, just with a local team, and you build a picture of the evidence. So if they've got a normal post-void bladder scan, you can start going, well, look, the bladder function is there. Okay, they don't have full-blown Cauda Equina R. Okay. So, what do I mean by cauda equina? Does anyone know?
Equina R.
Yeah, so you talk entities, so you've got cauda equina CES-SIR. S is suspected. So that's before they come into the door. Referral, bilateral radicular pain. Some altered saddle anesthesia. Retention. Okay? That's S. Then I get an MRI scan. Shows that there's a big disc, but there's a bit of space. But the bladder's still working. So it's cauda equina syndrome I. It's impending. Okay? Fine, don't need to do surgery now, but I might do surgery tomorrow, day after, next week. Keep an eye on your symptoms. If they change, you come in, emergency rescan. If you've now converted to R, you need to have surgery. But the natural history of the disc is that it will resorb slowly over time. So, if someone doesn't have full-blown cauda equina syndrome, if you give them time, this might resorb, and they don't go through the risks of surgery. Okay, surgery is not cost-free, causes back pain, has complications, has a risk of infection. There's high complication rates for cauda equina syndrome and long-term implications from chronic back pain stuff. Okay. So that's getting to decision making, what's the pros and cons. And this is the problem with most spinal surgery. There's not much evidence. Okay, and also not much good quality evidence.
My question is more practical, but what's the overlap between neurosurgery and orthopedic spinal surgery? Is it an operation? Is it no, I'll do it, no, you'll do it?
Here or in the world?
Do both.
I will choose my words politically correctly. No, so it's just what your service settings we are, because we're both capable of dealing with cauda equina, which is what your service setup is. It's just crossover, like hand surgery and plastics. Okay.
There's no skill set difference, you can say,
For cauda equina, no. Politically, there is no, but there is no skill set difference to what you do for doing a decompression or a discectomy. If it's because of trauma, yes, there's a skill set difference. We are used to instrumenting and dealing with bony fractures. Some neurosurgeons are perfectly capable of doing it. We have neurosurgeons trained who are part of the spine team here, which is spine. Can't say we're orthopedic spine because we're not. There's spine. That's neurosurgeons. So I can't be a neurosurgeon under their diet because I can't do the intradural stuff and so forth. I don't base a skull or anything above the head. So whereas the spinal surgeon is much greyer areas to what they do. So it's some of the deformity surgeons, which is classically not where the background is from simply looking at the bones and the screws. But they obviously deal with nerve roots and dura and all that sort of stuff and decompressions. It's just this area where the skill set mix, so it's very much what your service provides. Like you go to some places and it's purely neurosurgeons who deal with cauda equina syndrome. Here it's a mix. And the time thing, that's just a service provision issue. They're trying to change it, so it's only one, because obviously they've got two teams dealing with emergencies and there's not a direct handover. Yeah, so you have a 30-year-old lady who has a history of back pain and leg pain. Okay, and she's got some saddle numbness that all started 36 hours ago. MRI scan looks like this. Would you do an operation? Yes, no.
Sorry, what are the symptoms again?
So 30-year-old lady with 36-hour history of unilateral leg pain, which has got some labia numbness, sharp sensation. And as the head feels a bit, and so you look at there, that's a nerve root there. That one's clearly been squeezed quite hard. Yes, that'll probably be S1, maybe S2, pushing into those. Okay, so you could argue on the scan, okay, but you can't diagnose it on the scan. Okay, it's a clinical syndrome. But also, it's very hard to diagnose it clinically, so you need the both. So if they've got full-blown bladder retention, there's no pressure on the Cauda equina, not Cauda equina syndrome. Okay. So she had 36 hours unilateral leg pain that had gone into bilateral leg pain. So she primarily had left S1 nerve pain, this nerve here. So that was getting hit hard. And then she had a bit of intermittent right S1 pain. So it's clearly been irritated. You can see how this is now coming across the midline, pushing onto it. So you can see how you can build a picture, you can understand what's going on. Okay, it's never barn door. Okay? And she had some labia numbers. Okay? And it's 36 hours down the line. We'd literally just done one. And she arrived 10 p.m. on our doorstep. Because we said, look, a little later over, we'll assess it and re-examine. And so, you're 36, 40 hours down the line. Got an MRI scan that looks like this. She doesn't have bladder symptoms. She's got now bilateral radicular pain, but more so on the left than the right, and labia numbness. Okay. So, two options here. Okay. One is surgery. The other one is
Postpone the surgery.
don't do surgery. Yeah, basically, don't surgery, no surgery. Okay. Is she heading towards an operation? Yeah. Yeah. Okay. Okay. Now, when do you do the surgery? What are the arguments for and against?
Time frame. She's urgent but not emergent. Like not emergency situation, but it's urgent.
Okay. So why do you say it's urgent but not emergency? I'm not questioning you whether you're right or wrong. What's your reasoning?
Aren't involved. There is no sexual impairment.
Yeah.
The bladder is intact. The anal tone intact.
Yeah, it was.
Yeah.
Okay. So that's your argument for delaying surgery. So we all agree surgery. Now we get to nitty-gritty of timing. So it's literally 10 p.m., 11 p.m. Okay. We had theatre space. We've just done one. Okay, she's there. Okay, but it's late. Okay, as you know, complications are high out of hours, and we're nearly 2 days down the line already. Okay, so it's not as it happened just now, but quite acute. And we had a spare list at 8 in the morning next day. Okay, so I could operate on 8 in the morning next day. Okay, so that's the argument against. It's like she doesn't have sphincter discernence, but yes, she needs an operation. It's 11 o'clock. We've been up all day. We've been up till late the night before, some of that as well. Okay, actually, the delays in surgery is okay to have a safer operation in daylight hours with a spinal scrub team. This is why it's doing better to do it in there with the usual spinal anaesthetist, with the usual spinal scrub team. The scrub nurses that night, they don't do spines. Okay, we had microscope and all the other stuff, and big down stuff. It's fine, but they weren't the usual stuff, and that's before when you get into more complex surgery. Okay, so that's the argument for delaying it till the next morning. Valid arguments. Arguments for doing it at that point.
There is a risk of some sort of progression. I'm sure it's been slow, but
yeah. So there's a risk that she'll convert from a impending Cauda equina.
1 person for 1 hour.
Yeah. So there's a risk that she'll progress into retention, and it'll progress overnight. Okay. Hard to quantify that. When you say, look, it's already 10, 11 o'clock, so we're not even talking 12 hours. Let's say we, for whatever reason, it's a knock, it's what's there. We phone the anaesthetist, kind of already saying, by the way, you need to be around at 8 o'clock to start. She's fit and well. She's 30. She's fine. Literally, it'll be asleep, done, yours. Okay. No delay from that side, and we can wheel across the rest of that. So, risk of conversion. Okay. What's the other argument for doing it there and then, along that line? Because who's your perfect surgical candidate for Cauda equina syndrome?
One who doesn't have many symptoms.
Yes.
Not much damage.
Yes. Who is definitely going to progress.
Yeah.
Okay?
And you need space for that.
Yeah, and I'm talking about your perfect surgical candidate. Okay? So you want someone who doesn't have many symptoms, but you know is going to have Cauda equina in 12 hours or 24 hours. Okay? How many of those do you think we get where we know they're going to get Cauda equina syndrome? Okay? This is where the decision-making process comes into play. So the pros for her taking to theatre are she doesn't have bladder symptoms, but she's got some early symptoms. What else about it makes her a good candidate?
We're studying bilateral, so that's.
Being young.
Yeah, she's young. There's a lot to lose.
Yeah.
And this is where you medicine. I personally talk about a lot of certain things. It's not about being right. I want to do pediatric scoliosis. Okay. So let's say you put in 10, 20 screws. Okay. It's not about being right 9 times out of 10 or 99 times out of 10. Okay. Let's say I'm wrong with my screw placement 1 time out of 100, it's 1%. Okay, but you put in 10 screws a patient. You do easily 10 patients a year, so that means well over 1 patient a year, a kid, I'm going to screw up. You've got to put in back what is the consequence of being wrong. Okay? So if the consequence of being wrong is that she gets a bit of a sore toe or a numb toe, that doesn't matter. But your consequence of being wrong for her is then that she then develops Cauda equina retention. And what's the primary objective of surgery or treatment?
Prevent it from progression.
Preventing it from getting worse. Not from getting, I'll do this and it'll get better. The primary aim, so someone comes to me with disc prolapse and they have ridiculous pain going down their leg and I see them electric. I don't counsel them saying, I am going to not make the pain worse. It's not. The primary objective of that surgery is to improve their pain. And I'll say that there's an 85% chance you'll have a good result from this. And then there's maybe a 5% chance I will make you worse off. Okay? So that's how it comes to ridiculous pain, because that's a bit more reversible, because pain is the first thing, then it's sensory, then it's motor. Okay? So when I counsel someone for elective stuff where they've got a weakness, I say the aim of surgery is to stop it getting worse. I hope you get a recovery, but that's not why I'm counselling for it. Okay? So, what did we do? We took it to theatre straight away. Okay? Add into it, it was easy. Literally, we had nurses there. We weren't fighting with neurosurgeons, general surgeons, every other medical specialty at the JR. We were literally like, let's do it. Do the same again, guys. Yeah, great. You're all here already. The anaesthetist was there. She's fitting well. We went and collected her. Wheeled it. She was in theatre in 10 minutes, and we were done within an hour. Okay. And then, like I said, but this is where you make decisions. So the consequence of waiting 10 hours, whereas if it's been going on for a week, the ship has kind of sailed with, waiting another 5-10 hours isn't going to change your risk profile. But actually, this was under 48 hours. Is she high risk of getting a complication? No, it's not 5 in the morning. It's late, but we're not, falling asleep on our feet. It's not complex surgery. Okay, we were in it's easy to do. Anaesthetic wasn't at risk. We had a consultant, wasn't a junior anaesthetist doing all these things you can add into it. So actually, the risk of doing that surgery at that point was actually quite low. And then if you ever want to think about your decisions and see whether it's the right one, just add Your Honour to the end of the sentence. Why did you wait until the morning list to do it? I couldn't be bothered to do another operation, Your Honour. Did you have the facilities to do it? Yes. Were you incapacitated because you were so tired? No, just a bit hungry, but we ordered pizza. Honestly, we did. We had pizza between the cases. Which made a lot of difference for me because I hadn't eaten all day. So, Okay, did you have an empty theatre? Yes. Did you have a anaesthetist there waiting to? Yes. Had she signed the consent form? Yes. Was she within normal 48 hours of doing this? Kind of yes. So why did you delay surgery? Couldn't be asked. You know that there's potential, and she converted to, and as a spinal surgeon, you know full well that these are potentially unreversible, and she had minimal symptoms, and you had an MRI scan showing disc, and she had a history of progressive bilateral disc pain. That is an individual decision for her, but hopefully you've picked up all the tools to make that, and your ability to make a decision is something that I think is not taught in medicine anymore. And so it's these things that you'll get. You know, I couldn't have explained that, I could voice that at your stage. Okay? Like I said, I'm old, I've been doing this for a long time. And it's that ability to make it. Okay? They're not educated. They go, well, yeah, it was a bit funny when a week, you just got to stay connected. And a lot of what you do, it helps the patient a lot. So a lot of the conversation we have said is educating patients. Once they're educated, they know what to do with them, much happier. If they know when to activate, to us it seems easy. You kind of go, how have you sat at home weeding yourself for 3 days? Jesus Christ. But they're not educated. There's many reasons. There's not quite a clear cut as this. I mean, many other social factors at play. So you need to educate them with this and make sure they're aware. There is a risk of progress. Some might go, and we say that there is a risk this might switch instead. Some might go, thank you very much, can I have an operation now, please? Okay? Which is acceptable. Okay? But there is a risk of progression. And you then can do it, okay, that's fine. I wouldn't do it in the middle of the night. I might go, okay, that's fair enough. It's a big disc, you've got unilateral symptoms, you're safe netted. I agree you've got impending Cauda Equina. You're now appropriately safe netted. I'll put you onto the list in 1 week, 2 weeks, 3 weeks, kind of thing. Maybe 4 weeks. With clear instructions, you come back to A&E with this symptoms, these symptoms, these symptoms. And then it switches to that. There is a risk if you suddenly become incontinent that I may not be able to reverse that. Thank you very much. Because if you get into 4 weeks, you're going to look my leg pain is much better. The body sorted it out. The body's resorbed the disc. It's getting shrinking. And they get, oh, it's better now, thank you very much. I'm now not making a cut in the back. I'm now not taking away a bit of bone. I'm now not taking away some ligaments. I'm now not playing around on the nerve roots. This was stuck in the axilla on the nerve. You're at high risk of tearing the during CSF lead, which then increases your risk of infection, then increases your risk of not risk free. So this one, we didn't have a complication, but it's going to be really careful. Luckily, but the ones that are at a different position, they're at high risk of something happening. It's kind of creeps. So this would mean, so actually, if she had minimal symptoms, you'd be able to wait. And some of them come back and this is gone. When it's acute disc, it's not calcified, they do resorb.
Really sorry, I have to go.
No, that's right. That's done for my side. Any questions? I prefer direct feedback to my teaching, not boxes saying.
Don't worry, I'll arrange that. I usually send the feedback over.
No, that's fine. No, I prefer it directly.
Oh, right.
So in the sense of, don't tell you, lovely, great. I know I'm a good teacher. I've done a lot of this. Is that the structure you'd like?
Yes.
Yes.
Nice having us interactive with our station.
Yeah. I get bored of slides. Plus, I forgot I was doing this until they messed with me at 11 o'clock. I was like, oh, shit. Lucky it's a topic I know about. Anything to do differently you'd like adding in, like better drawings? No, it's quite handy. I've read from this, I can feedback and that. Cool. So, having a history, better history about bladder symptoms, okay? Better history about the duration, pre and post void bladder scan. Okay? And of all key teaching sessions, one, hopefully you've also learned how to teach better. 2, don't end with questions, thank you. End with the 3 points you're trying to finish with. Because you now remember that bit, not the last 3 points.
Thank you.
Thank you. I think that's all I want to go.